him to start screaming. If his airway's full of fluid, then sure, take the bulb syringe, suction. Squeeze the bulb syringe in so that you build up suction. Go into the mouth and be gentle with it. Now, mind you, you've done this like never, and so your fight or flight syndrome's going on, and you jam that bulb syringe into the back of the throat. Their vagus nerve is very accessible under the skin and under the tissue of the back of the throat. And so one of the things that they found is that with routine bulb suctioning, these kids were having bradycardic events because we were vagling them out. So just nice and gentle in, suction once or twice if you have to, if there's copious secretions. Otherwise, don't worry about it. Even if there's some meconium staining, a little bit, and they start screaming, it's okay, don't worry about it. Dry them off. We want them screaming. Put the little hat on their head. Put them up, turn them over, put them on mom's belly and chest, and let her, and then cover the baby up. You want skin-to-skin contact. Now, we want to do an Apgar score. Right? Appearance, pulse, grimace, activity, respiration. Right? 0, 1, or 2. So appearance. Is the kid blue? Is he pink? It's very common for the core, his face and chest, to be kind of pinkish, and for the extremities, the limbs to be blue. That's very common, but that's a 1. Kid comes out pink, that's a 2. He comes out all blue, that's a 0. So appearance, pulse, right? Is his pulse over 100? If his pulse is between 60 and 100, we ventilate him, right, with room air for 30 seconds. If it's below 60, we start compressions, all right? Now, neonatal resuscitation program has some different standards than the American Heart as far as, infant CPR and things, so I don't want to confuse things right now, but, so, compressions. But for the most part, this kid's going to look pretty good. Pulse, grimace, how's his activity? Is he, holding his hands, kind of shaking his fists at you, wiggling his feet, and yelling, right? So if everything's like that, that's a 2. If he's not moving at all, he's flaccid, that's a 0. Anything in between is kind of a 1. I just combined grimace and activity. Sorry about that. But anyway, and is the kiddo breathing? So we do that at a minute, and we do it at 5, in theory, if we remember. I'm happy with the kid's moving. He's pink in the trunk, and he's screaming. Now, why do we want this kiddo screaming? You got to remember that when they've been in utero, their oxygen exchange is taking place through their umbilical cord, the placenta, and mom's vasculature. Their respiratory system is working, their diaphragm, their intercostals, they are going through the motion of ventilation. And so they're actually inhaling, exhaling some of the amniotic fluid. But that's just building up the strength so that they can start breathing when they're out. So we want them screaming to clear their airway out. But also, if you look at their heart and their pulmonary artery and their aorta, they have the pulmonary flow to their lungs is not there because they don't need it. We don't want them absorbing amniotic fluid into the vasculature, right? So basically, the Reader's Digest version of this is that these are kind of clamped down. There's no blood flow getting through there. There's a ductus arteriosum. It's a little blood vessel that runs straight from the pulmonary artery to the aorta. So blood comes in through the vena cava, right atrium, left atrium, up into the pulmonary artery, or ductus arteriosum, and out through the aorta. And that's all oxygenated blood, okay, from mom. Part of this screaming starts to open this up and starts to close this down. it doesn't immediately close it down, but it starts the process. The little kids who stay blue even though they're breathing, a lot of times this is the issue, and they end up in Boston at Boston Children's having open heart surgery to close that. So that's why we want them screaming. Now, the last kid I delivered in this car in the rain, second child, came out pink from head to toe, no fluid issues, like looking around, moving his arms and legs, which was great. Never screamed once. Just kind of like cooed. Like, the kid looked like he was 2 weeks old. And although I was like drying him off and I wanted him to scream, he just didn't. But when I looked at him, he's pink. He's pink. He's in no distress. So it was just the weirdest thing ever. But it was perfect. Generally speaking, you want this kid screaming. So that's a normal delivery. What do we have for problem deliveries? Well, one of them is called shoulder dystocia. Shoulder gets stuck. So remember, one shoulder comes out, as that clears, the other one pops out. Shoulders get stuck, it causes some problems. The baby's stuck. But it can cause hypoxia in the child, which obviously, will lead to brain damage. But also a brachial plexus injury, which is the nerves that run down into that arm. And they can actually have paresthesias or numbness and tingling in that arm. And they can have paralysis in that arm from that. So what are the risk factors that kind of lead you to think about that? If the baby's too large, diabetic mom, right? Diabetic mom who's put on 50 or 60 pounds during this delivery, and this kid's huge, and she's telling you that, the last ultrasound said it was a big baby. Mom, did you have any problems with your last delivery? This in the car, this kid was 3-year-old was standing there looking over the back seat. Hey, Mom, when you delivered him, did you have any problems? No problems at all. If you had a previous shoulder issue, they're at risk for this again. Induced labor. So they've had to induce it. We're probably not involved at that point, though. And if the labor is going slow, sometimes a little bit, getting stuck. What do we do for that? Our EMT books never really address this. But you go to WebMD and it'll tell mom what to do. So you find this symphysis pubis bone, the pubic bone on the front, like right underneath where your belt would be. And you just kind of push down on that area of the lower abdomen on the uterus. A lot of times that'll pop that shoulder free and the baby comes out. Okay. The other thing you can do is put mom on her hands and knees. Just changing position. That's all you're doing by pushing on that area of the lower belly, upper pelvic area, is you're just changing anatomical positioning and allowing that to happen. The other thing is put mom on her hands and knees. Changes position, finish the delivery. Prolapse cord. So as the head's being delivered, you want to make sure that the cord isn't, coming out first. Because what's going to happen is as that cord is coming out and the kid's head is on it, his head is pushing it against the side wall of the vaginal vault, and it's cutting off blood flow. So the kiddo is still in, half in utero, partly out in the air, or not delivered at all yet, and he can't breathe, right? Expansion of the chest walls, not great, and his head's still in this area that's just, it's tissue and fluid. So this is one of the times where we would insert a hand into that area, and you just kind of gently put your gloved hand in between the head and the vaginal wall, and you're just trying to buy a little space so that that cord can continue to pulsate and perfuse. Cord wrapped around the neck. As the kid's coming out and you see it, it's like a leash, and it's going to keep the kid from being delivered well. Plus, you've got the whole cord being crunched thing. So just slide your fingers under the cord, gently kind of going around the head, cord up and over the head and allow the rest of the delivery. The ruptured uterus we talked about, true medical emergency. Inverted uterus. So we don't tend to see this too much with natural deliveries in our line of work because what have we been taught? Do not pull on the umbilical cord to speed up the delivery of the placenta. Doctors do it all the time. I watch these guys do it in the labor and delivery rooms, and the kid's been born and mom starts to push and they start yanking on the cord. And if that placenta hasn't detached yet, they'll actually pull the placenta out with, the uterus out with it. Jesus. The other problem that happens when you pull on that is that little pieces of that placenta can be stuck on the uterine wall, and now you still have that open gateway for blood flow, and you get postpartum hemorrhage. It's called retained particles of conception. So when you deliver that placenta, you want to look at it. The side opposite of the cord is this dark, almost like liver-colored look to it, and you want to make sure it's all smooth and there are no chunks out of it. If there are, you're going to have bleeding. Okay, it's time to go. So uterine, inverted uterus. There's also one, placenta accreta. The placenta is implanted too deeply into the uterine wall, and it's not delivering. So, like when I deliver a baby at home, you count on 10 to 20 minutes for the placenta to deliver. In that 10 to 20 minute time, I'm doing my assessment, I'm drying the kid, I'm putting the kid on mom, I'm reassessing mom, we're getting vital signs on mom. If I don't have a line in mom yet, I want to put a line in her in case we have some uterine bleeding, postpartum hemorrhage. And then, okay, I'm going to start getting mom, under a stretcher. But I'm going to plan on the fact that I'm probably going to end up delivering the placenta before we leave. I get to that point where I'm on the stretcher and I'm ready to go, and the placenta hasn't delivered yet, and she's got no urge to push. Okay, we'll head to the truck. About that 20-minute mark, I'm starting to get a little nervous about this, okay? So, placenta accreta. Nothing we're going to do about it, though. And then amniotic fluid embolus. This can happen up to, I think it's a month after delivery, where mom's bloodstream absorbs a little bit of that amniotic fluid, and it acts like, it's an embolus, right? It acts like a clot in a blood vessel. It can be cardiac, it's typically in the lungs though. It's typically pulmonary. But it can be in the brain, act like a stroke. It can be in the heart, act like a STEMI. And it can be in the lungs and act like a PE. Okay? So, keep mom warm. Keep the baby warm and dry. Start resuscitation on both if you need to. And remember that when we start bagging an infant, it's without oxygen to start with. You crank a neonate's oxygen levels up in the first few minutes after birth, and you can actually make them blind. If you want to check a blood sugar, you need to know what you're looking at, and you need to know what you're looking for. You can do a blood sugar on a kid with a heel stick. So like on an adult, you would do the side of the finger. You can do that on the heel of an infant. The only reason I would probably do that on an infant if he's sluggish coming around, that first 20, 30 minutes after childbirth, that kid's sugar, 30 to 50, common. And it's going to freak you out. Oh my God, he's hypoglycemic. No. This is normal for him. So his sugar's not going to start climbing until a little ways after birth. So a sugar of 30 to 50, not unusual. But know what you're looking for before you go looking for it, okay? If the kid doesn't respond after 30 seconds of BVM, because remember, a lot of times it's just getting their ventilatory system going and getting the air moving in and out. So just assisting ventilations usually is all they need. If you need to, then you can move on to bagging with oxygen. Don't forget that these kids, their necks are very weak, so it's easy to hyperventilate their head and actually occlude the airway going that way. Good BLS, hip tilt chin lift, jaw thrust, oral airways, the appropriate size to BVM. Okay, if you put a one that's too big on the kiddo, you're going to have a hard time getting a good seal. Okay. I think that pretty much covers it. If you have any questions, please feel free to email me, emsabounds@gmail.com. If you disagree with something I said, please feel free to email me. I'd rather answer your email than have nasty comments underneath my video. Anyways, thank you for your time. I appreciate it. Take care.